the Wadham Mass Gathering section. My name's Jamie Ranse. I'm the chair-elect of the Mass Gathering section for Wadham. We've been doing these webinars now for a few months, and we're starting to get some really good feedback from members and also some non-members about the value of these, particularly in terms of engagement with our broader community and linking up as a networking event across the globe. So we're still keen to hear feedback on what you think these are like and ways in which we can continue to improve our engagement with members. So at any point in time, feel free to contact either myself or Alison Hutton, who's currently the chair of the Mass Gathering section. We'll start very soon, as I can see more people are joining the sessions. And whilst we wait, I thought I might just give a brief introduction to myself. So my name's Jamie Ranse. I've been a member of Wadham for about the last 4 or 5 years now, previously involved in the nursing group. So I have a nursing background is my profession, and more recently becoming more involved in the mass gathering section. Professionally, I'm a registered nurse. I've been a nurse for about 15 years or so, and my discipline, I guess, is in the area of emergency nursing. I've been a volunteer with St John Ambulance, which is a out-of-hospital or pre-hospital service provider in Australia, made up of volunteers predominantly in most states and territories, although it also runs the ambulance service contracted by government in a couple of states and territories. I have been a volunteer with them for about 20-25 years now, and at various points in time holding high-level strategic roles nationally related to the practice of nurses, particularly from a governance and leadership perspective. That got me interested in the mass gathering world and disaster world as I was introduced as a clinician to various disasters, including bushfires and extreme weather events, or wildfires and extreme weather events. I was also introduced very early on to the world of mass gatherings as a clinician and have been providing a volunteer pre-hospital clinical services as part of St John Ambulance in the mass gathering environment for a number of years now. More recently though, we start to see an increase in the literature around mass gatherings, and I still wonder about the impact of mass gatherings on health services. My experience as a clinician in the emergency department sometimes was that the first time we would hear or know about a mass gathering that was on in the local area would be when the first patient arrives into the emergency department. There seemed to be somewhat of a disconnect between planners of events, managers of those events, and even government officials who knew of the events, filtering down to the health service level about what events were on and the likely impact of those. In some jurisdictions in Australia, ambulance service, the EMS service, has a disconnect from health. That is, it doesn't sit in the same umbrella as health, and it may sit in a community service or even a justice department. Therefore, when ambulance is planning their mass gathering strategy and approach to managing patients in that environment, sometimes they too don't talk with health, and as such we have this disconnect between the ability of health services sometimes to plan efficiently for events. Second to that, even if a health service knows of an event, my experience has been that they don't really change much of what they do about their service provision. They might not increase the number of staff they have on or the services available to patients in that environment. So my presentation today is a little bit about a research track which I'm starting around the impact of mass gatherings on ambulance services and hospitals to have a better understanding about what impact by having a mass gathering in your local community has on the service provision at those particular health services. So for my presentation today, hopefully I'll provide a little bit of an overview about some of the challenges that exist in providing adequate healthcare at mass gatherings, and we'll talk that in relation to what that means for health service provision. We know that a number of challenges do exist, particularly around egress to patients in mass gatherings. We know that challenges exist in terms of, if you do need an ambulance, do you have an ambulance on site at an event, or do you call an ambulance to an event, and the impact that that may have on the remaining community and the services of that community if you take an operational ambulance off the road. So to some degree, the idea of having different models of care at a mass gathering, which may include healthcare professionals, may be around trying to minimise the impact to those health services in the surrounding community or region. Therefore, depending on the model of care that you have on site at a mass gathering event, may actually reduce the need and impact on the local ambulance service and the local hospitals as well. So my aim for today's presentation is to discuss what we know about the impact of mass gatherings on health services from the literature perspective predominantly, although I've touched on some personal experience. And then secondly, to generate discussion amongst the people present today about the impact of mass gatherings from your experience in relation to health services. So the first thing I want to talk about is a literature review which we've undertaken with a broad range of clinicians, academics, emergency department staff or emergency room staff, from doctors and nurses, and together with ambulance services as well, in relation to what is already known in the literature about the impact of mass gatherings on health services. This is a broad overview about a potential patient journey through a mass gathering event, including first responders and sometimes lay people with a first aid certificate and perhaps some level of experience in the mass gathering environment, providing a health service on site or in event at particular events. And there's many examples throughout the globe about this, and I've already mentioned St John Ambulance in Australia that provides an in-hospital health, in-event health service in relation to this. Sometimes, depending on the extent of the event, the complex nature of the event, if it's multi-site, multi-day, hundreds of thousands of people, the in-event health services may also include healthcare professionals, being medical doctors, nurses, paramedics, or other allied health professionals. As I've mentioned, some of the key reasons of having these health professionals in the event health service is really about trying to reduce the impact on health services such as ambulance and hospitals by having a model that results in hospital and ambulance avoidance or reduces the usage of those services. We'll talk about a case study at the end which demonstrates a little bit of that. And then, of course, patients may move into external health services from this mass gathering, and that is the reliance on ambulance services to have EMT or paramedics assess and manage patients, transport to hospital, where then they have a hospital service available to them. So the aim of this literature review was to have a look at the literature and see what people have been writing about the impact on health services from mass gatherings. So we did a systematic literature review. We, as normal, browsed very strategically electronic databases, and we found various articles which had a focus on the provision of in-event health services, ambulance service transportation, and hospital utilisation, and that was the primary aim of this literature review. These were the key terms that were used for this literature review, and I won't go into them in great detail, but they did focus on the areas of mass gathering, EMS and hospital. There were many MESH terms, or the medical subject heading terms, which just don't marry up with this field. So many of these key terms were just that. They were the key terms that you see consistently in the literature in relation to this, so we adopted that as a part of our approach. And then we really wanted to include papers that were of real-world events not just a theoretical paper, about the various types of mass gatherings and people's input from an in-event or external health service. And as I said, we weren't looking at theoretical paper discussions or editorials. We also didn't look at the papers where mass gatherings were reported as a result of a disastrous event which occurred, because that would create a little bit of an anomaly to our literature, because obviously disasters or mass casualty events don't always occur at a mass gathering itself. So what we did find that there was over 2,000 articles related to mass gatherings. And this was really exciting. It obviously demonstrates that there is an increasing amount of literature in relation to the mass gathering scene. So we're quite excited about that. We also browsed the contents of the Pre-Hospital Disaster Medicine Journal, knowing that many articles related to mass gathering appear there as well. We found many articles that were obviously in both of those search strategies, which we removed, and then we started to screen and filter those articles for eligibility against our inclusion and exclusion criteria. And overall, we found 24 articles which were real world, talking about mass gatherings, where they mention in-hospital, pre-hospital, and in-event health services in relation to mass gatherings. Most of them were in relation to things such as patient presentation rates and transport to hospital rates and so on, but I'll come to that. This is a table which is obviously quite detailed. I hope you can read parts of that. And I won't go into it in too much detail, other than it provides a bit of a summary about the articles, which nation they originated from in terms of the event, what the event was, and as I said, the in-event health services and the external health services, where we have the patient presentation rates, the in-event health professionals, which we classified as either a yes or no, as in did they have in-event health professionals at the site, and then the transport to hospital rate, which is a reflection of ambulance or pre-hospital workload, and then the referral to hospital rate, which is those people that may have come by ambulance or EMS, or self-presented, or driven by a family member, or came by taxi, or however other people arrive at hospitals themselves. So as I said, we found 24 studies, which we included. All were case-based and retrospective in design, which was interesting. The majority of studies provided details of the in-event first data response services. And this was interesting because this seems to be the focus on much of the case studies that are published to date in relation to mass gatherings, talking about the in-event health services. And that's why I'm very interested in the impact on the external event health services, because there's not quite so much written about that. And the stuff that is written is predominantly as a flow-on effect or as a result of talking about the in-event health service literature, rather than being a standalone focus. It's obviously varied in reports of the number and type of in-event health professionals. As I said, we listed them as yes or no because it became too difficult to try and categorize in any other way the types of health professionals which were on site at events. All the articles reported that patients were transported to hospital by an ambulance service or an EMS service, and that's all they say. They don't provide much more detail than that and the impact on that ambulance service. And 9 articles out of the 24 reported about patients presenting to hospital. So as I said, the emphasis here is really on the in-event health service rather than the external health services to major events. And often the impact on those ambulance and health services is just not reported. It's just not spoken about in the literature. So as a result of this literature review, we can make a small conclusion. Really, there's minimal research focusing on the impact of these mass gatherings on the external health services, particularly ambulance service and hospitals. So as a result of this, we think that there needs to be some work undertaken, particularly around mass gathering research and evaluation, to start linking that patient level data from an in-event health service to the external health services such as ambulance and hospitals. This paper is although I've just spoken about it in quite briefly, it's been accepted for publication in the pre-hospital disaster medicine and should be available towards the end of this year or early next year. So that leads us to a bit of a case study. So knowing this, we wanted to then explore one event in our local area that had a focus on, the study had a focus on the impact on external health services. So we looked at this case here, which again was a research case study which we undertook with our local health service providers, that being our local ambulance service and local hospitals. And I'll talk a little bit more about that in a moment in terms of the setting. Again, with some of the academic institutions around Canberra and Australia that have some involvement in mass gathering health or mass gathering medicine. So for this research study, we knew that most of the literature relates to on-site care from single events when talking mass gathering cases. We know that it does not comprehensively consider the effect on that pre-hospital or ambulance and hospital services, and therefore that was what we wanted to focus on for this research. To start off with, we started looking at one outdoor music festival which is held in Canberra. Canberra is the national capital for Australia. It's an inland city. It's quite isolated from other major metropolitan cities. It has about 300 to 350,000 people residing in the city, and we wanted to have a look at an event that's held in this location. It has two major public hospitals, therefore we felt that it would be easier to track patients from this event to those hospitals, as we would only need to go retrospectively through those patient records from those two hospitals. Additionally, it only has one ambulance service or EMS provider, and therefore we'll be able to start to link some data between our in-event services to that ambulance provider and then to the two hospitals themselves as a bit of a case to test out some data linkage systems that aren't quite strong methodologically here in Canberra, and also to start something small in terms of exploring the impact on those health services. So as I said, our design was a retrospective review. We looked at patient records from the on-site health services at one outdoor music festival. The other reason we chose an outdoor music festival was because we had undertaken some research in relation to understanding patient presentations at outdoor music festivals previously. So we had a good understanding of that environment in terms of patient presentations to outdoor music festivals. Spoken a bit about the setting, that is, it was one outdoor music festival in the Australian Capital Territory, Canberra, and it had a population of about 20,000 participants. So there were about 20,000 people who turned up to this music festival. It had one first aid post staffed by volunteer first aiders from St John Ambulance, and then it also had a small health team staffed by doctors, nurses and paramedics, and it also had an on-site ambulance from the local ambulance service. So we collected data from this event using patient care records. They were quite comprehensive, and we were able then to use the demographic data on these patient records to link with the ambulance and hospital health service data as well. Our data analysis was somewhat simple descriptive data. We were really just interested in how many people were going and where they were going, and perhaps what interventions they had as well. So most of it was descriptive statistics in relation to that demographic and patient presentation details. We did do a Mann-Whitney U test just to explore the length of stay between the on-site healthcare area and those people who may have been referred to the on-site health care professional team. So looking at those, the length of stay with first responders versus the length of stay if they were to go with the health professionals. And this was a research project which was approved by our local area ethics committee to undertake. So out of the 20,000 people, we had 197 people, or 9.85 people per 1,000 present for on-site care at this event. Bring up some of the demographics in relation to this event and people who presented to on-site first aid care. Hope that's large enough for you to read. But you'll see some interesting things here. Firstly, the majority of people were female. 64% were female. The majority of patient presentations and the primary presentations were related to illnesses. Now, for the categorization of this data, we used a minimum data set that both Alison and myself have previously published in 2012 about establishing the need to establish a consistent way to research and evaluate mass gatherings, therefore allowing for some meta-analysis to occur across events globally so that we can have a better understanding about what types of patients present to what types of mass gatherings. So by no means is it 100% complete and accurate and the best, but it was at least a starting point, and that's what we've used to categorize patients on this occasion in terms of their presentations. So this is the primary presenting breakdown of presentations on this occasion. Interestingly, the majority of the 197, as we would expect, were discharged or returned to the event, and 24 people were referred to, the on-site doctors, nurses and paramedics. Well, what we know about the Outdoor Music Festival in general is that most people do not become acutely or severely unwell, that most people will have minor injuries or illnesses, and those that have injuries, the majority of them will be to distal limb injuries, and most people will return back to the event or go home as a result of their injury or illness, where only a small proportion will actually require referral to ambulance or hospital services. That was similar on this occasion, where 24 people were required to be referred to, the on-site doctors, nurses and paramedics. This here is a little bit of a breakdown of the types of people that we saw. As you can see here now, there's a little bit of parity between male and female in terms of their presentations. There were equal proportions of males and females, whereas previously we didn't see that. The other interesting thing to see here is that the treatment length of stay at the on-site first aid care providers was about 11 minutes. On average, whereas with the on-site healthcare professionals, it was 76 minutes. We've got some theories in relation to that. In terms of the primary presenting cases to the on-site healthcare professionals, the majority of them were related to environmental. Now, in our minimum data set, which we have at present, environmental includes things such as alcohol and drugs and other substance overdose or excessive use of, intoxication of those substances results into the environmental category. So at this outdoor music festival, you see that 50% of the people who were required to see the on-site doctor, nurse or paramedic were in relation to the environmental aspects. I guess more broadly, there's a need to do something similar to this in terms of exploring the impact on external health services from a mass gathering at a multi-site approach, whereby you won't have the anomaly of one category being predominant in a presentation rate. Here you see that in outdoor music festivals that would unlikely be the same if it was at a concert of some description that's of a different nature, or a local parade, or an agricultural festival, or New Year's Eve perhaps. But different events are going to have different patient presentation types. Of the 24 people who required some assistance by doctors and nurses and paramedics on site, 2 were discharged to the local police or law enforcement services. They were discharged based on the fact that they were quite aggressive in nature and didn't require hospitalisation, but were alcohol or drug affected. 7 required transportation to hospital, and 15 returned to the event. Now, arguably, and it obviously requires further investigation and research, but those 15 people who were returned to the event after seeing a doctor, nurse or paramedic who may have on average stayed with them for 76 minutes may have in fact, if the doctors, nurses and paramedics were not on site, been transported or referred to hospital. And therefore, with a broad stroke of a brush, you could argue perhaps that we might see some parts here which relate to a model of care that results in hospital avoidance and ambulance avoidance for this event. However, as I say, it's very, very weak in relation to the number of patients and so on, and it just needs more further investigation about those models of care. So 7 were transported to hospital. Of the 7 which were transported to hospital, 5 ended up in the emergency short stay unit, and they were there for less than 24 hours. 1 required a operating theatre admission where they had an open reduction internal fixation of a distal limb fracture, and the other required intensive care admission and ventilation for a couple of days. Of the 7 patients which were transported to hospital, ambulance paramedics undertook a number of interventions. 3 patients received artificial airways, either nasopharyngeal or oropharyngeal airways. 1 patient required in-event on-site endotracheal intubation, and most of them required some type of sedation or opioid analgesia during transportation to hospital. So this is just a bit more of a broad overview and overview as well about some of the results that we found. The most frequent illness was headaches to on-site first aid providers or first aid carers, and in most cases was related to dehydration and so on. Most of the injuries were superficial lacerations, as I said, of distal limbs, people not wearing appropriate footwear, and so on. And the environmental was substance and alcohol intoxication. And of those, 12 people who presented to the on-site first aid care in relation to the environmental factors were all referred to the on-site healthcare professionals. Here we saw that the most frequent related illness was for headaches, and the injuries were fractures. As I said, one of the fractures was transported, well, both were transported, one requiring surgery. Ambulance transport, again, fractures and the environmental aspects of substance use and alcohol intoxication resulted in the workload for ambulance. On this occasion, whilst there was an on-site ambulance for transportation of patients to hospital was diverted from the normal community health operations. So a ambulance which would normally be seen and treating, or paramedics which would normally be seen and treating patients within the local community was diverted to this event for the purpose of transporting people to hospital. 1 patient, as I said, required intubation, 3 airway adjuncts, and when they got to hospital, patients had theatre or an intensive care admission. So I'll slowly start to wrap up now and have a brief discussion about what some of this may mean. Well, this does provide some insight into the health service usage from one event, and it is only one event, and in fact it's probably quite a small event with only 20,000 people. It was a good place to do this though, to get an insight into what the impact might be, and the impact, I guess, overall is relatively small, and that may be influenced by the model of care, which is engaged in the in-health service providers in the event itself. The presentation to the on-site health professionals resulted in a longer stay. As I said, it was about 76 minutes on average that a patient would stay with the on-site health professionals, and this may be in relation to the fact that they were having a hold rather than scoop and run type approach to the management of patients there. As I said, there's possible a hospital or ambulance avoidance of 15 patients from this event. I think there needs to be more methodological work done about how we could measure some of these aspects about hospital or ambulance avoidance. And as I said, this needs to be undertaken more broadly in a multi-site research approach so that we can explore the nuances between different event types and different patient populations and different models of care in relation to health service usage from mass gatherings. So that comes to the end of my presentation.